Hello everyone, this course is a part of the project funded by the European Union and Russian Federation. The name of the course is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of this course is Fight with Colorectal Cancer. My name is Denis Shimchikas and I work at the Day Surgery Center of Republican Klaipėda Hospital and in Klaipėda University. This is fourth episode of this course, and I'd like to continue my talk about performance measures in colonoscopy in our everyday practice. As a frame for my talk, I use beautiful guideline published by European Society of Gastrointestinal Endoscopy in year 2017. The authors of the guideline divide the pericolonoscopic period into 7 domains. Each domain has one key performance measure and sometimes has at least few minor performance measures. In previous episodes, I was talking about the first pre-procedure domain and talked about the consultation indication for colonoscopy, time slot for colonoscopy, and the rate of adequate bowel preparation. Now I'd like to continue my talk about the second domain, which is completeness of the procedure. After bowel preparation, patient comes to hospital and we start the procedure with the sedation. Next, we insufflate the gas and insert the colonoscope. Talking about the sedation, I must say it's a great thing that year after year more colonoscopies are performed with intravenous sedation. Why? Very simple reason. The patients who had colonoscopy without any sedation, they in many cases used to come home and tell their relatives that colonoscopy is an awful thing and they say don't go for the colonoscopy. And now with intravenous sedation, patients' experience is much better and the fear to have colonoscopy is much lower. Intravenous anesthesia is for patient comfort and for better work quality of endoscopists as well. While anesthesiologists and anesthetists do their job, I do my job giving all the attention to the monitor. Usually anesthetists and anesthesiologists give deep or moderate sedation using propofol alone or in combination with any other drug. Pardon, some other drug. Of course, more medication anesthesiologist gives, more work he or she has in follow-up of patient responsiveness, airway, spontaneous ventilation, and cardiovascular system. So when the patient is sedated, we insufflate the gas. We use CO2 gas because there is enough scientific data for making conclusions that CO2 insufflation improves patient comfort without compromising colonoscopic performance. Here is one example of meta-analysis of carbon dioxide comparing with room air. You can see here the tank of CO2 attached to the tower of colonoscopy equipment. So we insufflate the gas and insert the colonoscope through the anus. And for the endoscopists, I would like to remind that during the insertion and a whole colonoscopy, ergonomics is extremely important. If you are comfortable, you feel less tired, and that gives much more safety for your patient. I would like to share a screenshot from beautiful video of American College of Gastroenterology, which reminds us that many endoscopists actually have pain in neck, in spine, or wrists. And that is actually possible to prevent taking care of work ergonomics. Most common mistakes are viewing angle too high, distance too far. In this position, endoscopist's head is lifted up and the neck is bent. Correct distance should be between 90 and 180 centimeters. And the monitor should be around 20 centimeters below endoscopist's head. Also, table where the patient lies usually should be higher than it is, and according to the ergonomic rules, the table should be 10 centimeters lower than the endoscopist's elbow. Now let's talk about the insertion technique. I will not go here too much into details. I will just remind that there are many techniques and basics are tip deflection, push forward, pull back. Shorter it is called push-pull technique, and it gives us good chance to put all the colon on the endoscope. Also, we make torque, we do air insufflation and suction, and of course all these mentioned maneuvers we use all together. For example, we suck the gas out and push the endoscope forward. Advanced techniques are jiggling and shaking, right turn, left turn, shortening, a hooking technique, slide by technique. They are beautifully described in at least few articles. Auxiliary techniques that are commonly used are position change of examinee, abdominal compression, water infusion technique. What I do most commonly is I start the colonoscopy in patient's left lateral position. I reach the splenic flexure. Then very often it starts difficult to climb to the transverse colon, so we rotate the patient on the back and reach the cecum. If there are any obstacles, I ask the nurse to compress the abdomen in certain points. And of course, I try to remind myself that no matter what level I am, I must read, watch videos, observe other endoscopists, practice, and avoid the push unless I know where the tip of the endoscope is going. Nowadays, there are many sources to learn from, and many of them are totally for free. In this list, there are only few examples, and even here, the whole colonoscopy procedure is divided into segments and divided thoroughly. Described thoroughly. Some of videos should not be a good example for us. For example, This video shows very fast insertion of the colonoscope. And I would like to remind that please don't rush. Colonoscopy is not a horse race. While insertion, we should make the plan for the therapy. For example, what I do is I look for gross pathology, explore the situation, and that after cecal intubation, I would have an action plan. I'm sorry, I would like to repeat that during the insertion, please don't rush. While insertion, make the plan for the therapy. I usually look for gross pathology, explore the situation, that after cecal intubation I would have the action plan. For example, if I find the early colon cancer in hepatic flexure, it is clear that in the future there will be necessary right hemicolectomy. So there is no need to perform polypectomies in the right colon. But if during the insertion you are in a hurry and you perform insertion, for example, in 1 minute, but you miss early cancer in hepatic flexure during the insertion, you perform the polypectomies here, and only later you find out that there's a cancer here. So in the end, you lose time and you give more risks for the complications. So we inserted the colonoscope, and now let's talk about the second key performance measure, cecal intubation rate. What does ESG guideline says? It says that cecal intubation rate is the percentage of colonoscopies reaching and visualizing the whole cecum and its landmarks. Whole bowel examination is a prerequisite for complete and reliable inspection of the mucosa in search of lesions. A low cecal intubation rate is associated with an increased risk of interval colorectal cancer. Incomplete colonoscopy leads to increased costs and inconvenience as the examination has to be repeated. Minimum recommended standard is more than 90% and target standard is more than 95%. Cecal intubation, meaning complete visualization of the whole cecum and its landmarks, should be documented in a written report as well as with photo or video documentation. What are our results of cecal intubation rate in our day surgery center? In our first 400 colonoscopies, we reached the cecum in 98% of the cases, which is a very good result. Unfortunately, we did not reach cecum in 7 cases, and the reasons were: in one case, atrial fibrillation paroxysm occurred, and we had to end the procedure. Luckily, in this case, the biopsies from the rectal cancer were done before the atrial fibrillation started. Also, there were 2 cases of bad bowel preparation and 4 cases of colon stenosis. The reasons for stenosis were 1 cancer, 1 endometriosis, and 2 diverticulosis cases. What about terminal ileum intubation? The authors of the guidelines say that for the purpose of colorectal neoplasia detection, terminal ileum intubation is useful only to confirm completion of the colonoscopy when classic cecal landmarks are not confidentially seen. In our practice, we always try to intubate Ilium, especially in younger patients or diarrhea cases. And there are at least few techniques to intubate Ilium. My personal favorite first rule is gas suction from cecum, which makes the ileocecal valve to look at you. This is the end of this episode, and in next episode I would like to talk about identification of the pathology. Thank you very much for your attention.